Okay, so some of the expectations are we expect to know how to make quick identification of emergencies, management, prevention of the reoccurrences. That's from Jennifer. Thank you, Jennifer. Bosco expects to learn how to do emergency management in Addisonian crisis. Okay, we can keep the expectations coming in the chat. Okay, so we'll have a brief introduction of part of the team, and we'll start with Dr. Ronald.
Okay. Good afternoon, everyone.
Good afternoon, Ronald.
Welcome, Adrenal. By names of Kantu Ronald. I raised the age of internal medicine. And I'm happy to be here.
Okay, thank you, Ronald. So that's Ronald. Ronald will be giving us a case presentation and a reaction, and then we'll move on to Mr. John Osire.
Thank you very much. Osire John Andrew, my name. I'm a critical care nurse. I work in Mulago, currently the deputy in charge ICU. Thank you so much, Dr. Maria.
Thank you, John. Once again, John is going to be talking about the nursing management of the patients with the emergencies. Let's move over to Connie. Yes, Connie Baluka, are you able to hear us?
Good afternoon, everyone.
Yes, good afternoon,
Yes.
Connie.
I'm called Connie Baluka, an
Yes.
emergency medicine resident at MakCHS. Thank you.
Okay, you're welcome. So Connie will be giving us an approach to a patient with either of these emergencies. So we have another person on the panel, and with us is Dr. Jimmy Atera that will be overlooking everything. Okay, so shortly we shall have a pre-test that will be done to assess the knowledge and then see if there's been any improvement post the session. So the poll starts. Are you able to see the poll on the screen? So the poll on the screen is going to last exactly 5 minutes.
best friend is. But of course, sometimes you not tell it to anyone.
Once again, if you have any expectations for the program today, you can send them in the group chat.
Can't hear anything. Is everything okay?
Yes, everything is okay. Yes, everything is okay. We are still waiting for you to complete
You are ready for now.
the pre-test.
Right.
Recording in progress.
Okay, so next we shall have Dr. Emmanuel introduce ourselves to us and let us know how he'll be part of the program today. Yes, Dr. Eemu, are you able to hear us?
Yes, good afternoon, everyone.
Good afternoon.
I'm Dr. Emmanuel, President of Anesthesia and Critical Care. I will be responding to questions on the chat once the session starts.
Okay, thank you, Dr. Eemu. All right, so we'll go ahead and have our very first presentation by Dr. Ronald Kantu.
Okay, thank you very much. I'll head straight to the presentation. So I'll be presenting the case for today, and I'll go straight to the I'm going to present a 39-year-old female who came in with a presenting complaint of loss of consciousness. It was for 1 day. So she was a known hypertensive for 6 years on bisoprolol 5 milligrams twice a day. She had been referred from Masaka Regional Referral Hospital due to a 1 day history of sudden loss of consciousness, which was preceded by sudden onset of severe generalized headache, 6 episodes of non-projectile vomiting, and neck swellings with progressive weight loss, increased sweating, palpitations, insomnia, fatigability, and progressive hearing impairment, with the left ear being more affected than the right, and blurring of vision, with the left eye being more affected, and heat intolerance for the last 3 years. So in the primary survey, for the airway, it was patent, though threatened by reduced levels of consciousness and the bilateral neck swellings. So the action taken was to maintain the patent airway, which was done through positioning. Then for the B, breathing, she wasn't in distress. She had a clear chest with a respiratory rate of 16 breaths per minute, which was normal, and an SpO2 of 98% on room air. So we had continued monitoring. Then for C, saturation, her BP was quite high. She had a BP of 160, over 119 millimeters of mercury at admission, with a pulse rate of 96 beats per minute, regular with a full volume, and warm peripheries with a normal capillary fill less than 2 seconds. So here we're to get an IV access line and take off blood samples for lab investigations. So in the D, that is a disability, she was semi-conscious with a GCS of 11 out of 15, and restless in bed, though with a soft, and though her neck was soft, the pupils were equal and reactive to light, but with a left facial nerve palsy. And here we maintained her in we put her in a recovery position, passed a urethral catheter, then ordered for an urgent brain CT scan, and also inserted an NG tube for feeding. So in the E, that is the exposure, axillary temperature was 36.6, which was normal, and she had no life-threatening injuries. So we'll continue monitoring. So in the secondary survey, that is head-to-toe examination, general condition was fair, no jaundice, no pallor, no finger clubbing, no cyanosis, no edema, well hydrated, but with marked cervical lymphadenopathy. So in the cardiovascular system, the pulse rate was 96 beats per minute, regular full volume pulse, symmetrical and synchronous, that is the radio and radiofemoral. Then the blood pressure was a bit high. She was hypertensive with a blood pressure of 160 out of 119, with a normal active precordium apex beat in the 5th intercostal space. And heart sounds 1 and 2 were heard with no added sound. In the respiratory system, she was breathing at a rate of 19 cycles per minute. She was breathing at a rate of 19 cycles per minute with a normal chest, and the chest wall was moving symmetrically, and having vesicular breath sounds with no added sounds. In her abdomen, she had normal fullness and was moving with respiration with a phanestrial scar. No tenderness and no palpable organs were noted. Then ear, nose, and throat, she had good oral hygiene, no nose or ear discharge, and there was no pain. Then in the central nervous system, she was restless in bed, semi-conscious with a Glasgow Coma scale of 11 out of 15. Eye opening was 4, motor, best motor response 5, and verbal a 2. with a soft neck. Cunnings and Brudzinski were both negative. The pupils were equal and reactive to light with 3 millimeters in diameter of the pupil, but she had a left lateral gaze palsy and a facial asymmetry with a deviation to the right, and left-sided tongue atrophy with loss of papillae. In the sample history, for the S, that is the signs and symptoms as noted above, she had progressive symptoms over the past 3 years, that is prior to admission. She had history of progressive hearing and visual impairment, weight loss, facial asymmetry, insomnia, excessive sweating, palpitations, and bilateral neck swellings. So on admission, she had sudden loss of consciousness and vomiting. Then in the A, that is the allergies, she had no known food and drug allergies. The medications she was on, at admission, she was on amlodipine, taking a dose of 10 milligrams. She had been taking amlodipine 10 milligrams, that is once a day for the 4 months prior to the current condition that had brought her to hospital, and also bisoprol 5 milligrams. And for bisoprol, it was 2 months prior to admission, and paracetamol, which she had been taking for 1 week prior to admission. Then in the P, that is past medical history, she was a hypertensive, which was known for the previous 6 years, and she was on treatment with good adherence in the prior 4 months prior to the admission. So this was her second admission in 2024 with no history of surgery, no history of blood transfusions, and no history of any major traumas. Then she was a mother of 9 with a 3-year history of amenorrhea, though not on any contraceptive method. She was married and had both parents still alive with no familial illnesses and no history of smoking or alcohol consumption. Her last meal had been 6 hours prior to admission. So in the events surrounding the events, she was observed to have acutely lost consciousness while at home, then fell to the ground, but got no convulsions, and she started vomiting, which was approximately 15 minutes after the fall, though she had no history of any trauma to the head during the fall. So in the problem list, help me scroll. In the problem list, she had reduced level of consciousness. As you remember, her BCS was 11 out of 15. She was in a hypertensive emergency. She had those very high BPs and compromise to her CNS. Then she had bilateral neck swellings, which had been there for quite some good number of days, that is approximately 3 years, and also vomiting. So in the investigations which were ordered, we did a brain CT, which we didn't include here because immediately after brain CT, we went ahead and did a contrasted. The first one was non-contrasted, which gave findings of what was suspected to be to have been a petrooliviomeningioma, but on doing a head and neck CT, contrasted CT. So the conclusion was what was found were features of bilateral enhancing masses, which were arising in the carotid spaces, with the left being greater than the right at the point of bifurcation of the common carotid artery, with associated marked temporal and petrous apex and inner ear infiltration, with the left being much more greater than the right. So there was also note made to the infiltration of the optic chiasm with bilateral complete post-obstructive chronic mastoiditis, and a conclusion of a possible bilateral glomus jugular was made. Then a brain MRI and MR angiography was also done, which gave us cervical, which gave us the following. So it was noted cervical portion of the right, of the cervical portion. I think there is some word that is missing here. Then for the neck ultrasound scan, it revealed bilateral complex masses and a normal thyroid gland. Then the thyroid function tests that were ordered all came out normal, with a normal TSH, normal T4, and normal T3. For the CBC, the only marked finding was a low MCV, which was 64.2, and the low MCHC, which was 19.6. The hematocrit was normal, and the white cell line were all normal. So in the liver function tests, she had alterations in the AST, which was 89, which was approximately 2.8 times the upper limit, and ALT, which was 68, and a little bit higher than the normal. Then the total protein and albumin were normal. For the renal function tests, they were basically normal serum creatinine and urea, with the normal electrolytes, sodium and potassium, all. So for the management, she was given IV labetalol immediate at admission in the emergency unit. She was given 20 milligrams of IV labetalol, and mannitol 20 grams. And she was switched from the oral paracetamol that she had come in to IV paracetamol at 1 gram, that is 8 hourly. And she was to continue with the antihypertensives. And we initiated on doxazocin, that is 4 milligrams once a day. And she was also given a shot of dexamethasone, 16 milligrams intravenously. So for the supportive management, we raised the head of the bed to 30 degrees. A catheter was passed, a urethral catheter was passed, and a fluid balance chart was also started. Then she was to be regularly turned in bed, and BP and random blood sugars were to be monitored regularly, with also NG tube feeding 3 hourly. So in the follow-up and disposition plan, so this patient, after 1 day of management at emergency ward, had regained full consciousness, but still had fluctuating high BPs, and these blood pressures could go to as high as 230 over 138, and to as low as 110 and 68. Then she was admitted to neurosurgery ward for further evaluation and review by the neurosurgeons. And the urine metanephrine tests results were still pending, and nuclear medicine studies hadn't also been done yet. So basically, that's what I had to say.
Thank you, Ronald, for the wonderful presentation. We'll move on and have reactions. In case you have any reaction to the presentation, any question, you can either put it in the chat or you could raise your hand and voice it. So why was the dexamethasone given? Hanifa wants to know.
Okay, so the dexamethasone was given, I think the justification was at admission, the admitting doctor suspected this patient to possibly be having a raised intracranial pressure from what is suspected to be a brain tumor. That was prior to the radiological investigations that were done.
Okay, and then the monitor?
The monitor was also for the same thing, was trying to manage the raised intracranial pressure, which is suspected.
All right, thank you. Someone wants to know why you gave doxazocine again to the patient.
Doxazocine was given because at admission, yes, they had quite a number of differentials, one of which was they were suspecting that this patient could be having a catecholamine surge, and due to the history of the fluctuating BPs and the headaches in a hypertensive patient with uncontrolled BPs. So they were suspecting this patient could possibly be having a pheochromocytoma undiagnosed. So since this patient had already been started on beta blockers, so at this point in time, since she was still presenting with the excessive sweating, the palpitations and anxiety symptoms, they felt it wise to start the alpha blockade at this time, at this point in time. So that's why they had to add on the doxazocine.
Okay, thank you, Ronald. So Arik in the chat also wants to know why aldosterone renin ratio was not done for this particular patient.
I forgot. I just forgot it was one of the pending investigation results that were not gotten by the time when I wrote up the case. Those were some of the other results that were still pending that had not been done.
Okay, thank you. And Andrew wants to know what are the signs of raised intracranial pressure in this patient.
So according to what I presented, this was well, like a summary of what had transpired. But at admission, the admitting doctor had noted down a patient who had been referred from Masaka with a history of sudden onset of severe headache, a non-hypertensive history of sudden onset of severe headache. Patient was restless in bed, and the initial doctor's examination findings had showed neck stiffness, which later on at my evaluation, I found that had not been there. So I would justify his initial evaluation where he felt like maybe this patient had raised intracranial pressure because of the sudden onset of the severe headache, the loss of consciousness, and the neck stiffness, which he had noted in the admitting notes.
Okay, thank you, Ronald. So If you have any more questions, please continue with them in the chat, or you could raise your hand, and then we shall have Dr. Eemu responding to these questions. In the meantime, we are going to move on to the next presentation, which is approach to a patient with adrenal and pituitary emergencies by Dr. Connie Baluka. Dr. Connie, are you ready with your presentation?
Thank you, Maria. Hillary, kindly put slideshow. Okay. Thank you, everyone, and welcome to this echo session. Like already introduced, I'm called Dr. Baluka. I'm glad to be back here. You will allow me to present without my video on, trying to conserve battery. I'm quite in a remote area. So we're going to be looking at an approach to a patient with an adrenal or a pituitary emergency. And at this point in time, I want us to first review the functional anatomy of the adrenal glands. So we know that the adrenal glands are some two small glands located above both our kidneys in the abdomen, and we know that they are retroperitoneal in sight. So the adrenal glands have two parts: the cortex and the medulla. So the cortex is the outermost, and then the medulla is what is inside. So the medulla gives us the catecholamines, that's the epinephrine and norepinephrine. We all know that epinephrine and norepinephrine are part of the sympathetic nervous system that is activated in times of fight or flight. We all know that. When we say you have an adrenaline surge in case you are scared of something, your adrenal glands, particularly the medulla, is going to produce adrenaline, and it's going to race up your heart. It's going to increase blood supply to your brain so that you think. It's going to open up your eyes so that you're able to run away from danger. So that's what the medulla does. It basically produces epinephrine and norepinephrine. The cortex has three parts, and these three parts are the zona glomerulosa, zona fasciculata, and zona reticularis. So the glomerulosa gives us the mineralocorticoids. So mineralocorticoids are basically aldosterone. Aldosterone is important in maintaining our blood pressure, and it's secreted via the renin-angiotensin aldosterone system. I'm not going to go in deep details of how the RAS system works, but when your body, when your blood pressure drops, and it's recognized by the amount of blood reaching your kidneys, some cells in your kidneys are going to stimulate the release of renin, which is going to stimulate the release of angiotensinogen, and it will stimulate the release of aldosterone. So aldosterone in essence helps to excrete potassium in exchange for sodium. You know the saying, where salt goes is where water goes. So when you have sodium being retained, you have water follow it, then you have an increase in blood volume, and in return, you're going to have an increase in blood pressure. That's how aldosterone works. The next one is glucocorticoids that are produced by fasciculata. Now, the fasciculata or the glucocorticoids are also called cortisols. They're also known as stress hormones. And this hormone particularly is produced in times of stress. So you could be stressed by illness. You could be stressed by an injury. Let's say you got an accident. You could be stressed psychologically. So this cortisol is produced by the hypothalamus pituitary adrenal axis. And it works by form of a negative feedback mechanism. So when you have a process of stress, your body is going to release corticotrophin releasing hormone, and it's going to be released. It's going to be sent down to the pituitary. The pituitary will release adrenocorticotrophin hormone. The adrenocorticotrophin hormone will act onto the adrenal glands, and particularly the zona fasciculata is going to release cortisol. So cortisol will increase the rate of metabolism. It's going to increase your blood pressure. It's literally it's a driver of things in your body. That's what cortisol does. Cortisol is very, 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 very important for our day-to-day lives. It's very important for our sustainability. If you don't have cortisol, the chances that you're going to become hypoglycemic are going to be very high, as we shall see along the way. The last one is zona reticularis, and it produces hormones such as the androgens and estrogens. So these are secondary sources of sex hormones, so we are not going to really go deep into it. Next. That's just something to remind you of which part of the cortex produces which hormone. Next. So this is also just showing us how the hypothalamus, anterior pituitary and adrenal glands work in the hypothalamus pituitary adrenal axis. And the picture on the right is showing us how the RAS system works. Okay, next. So like I earlier mentioned, the adrenal glands are responsible for secreting hormones that help us in metabolism, blood pressure regulation, maintenance of a normal immune system, kickstarting the sympathetic nervous system, and how our body responds to stress. So after us reviewing the physiology and the anatomy, the normal of the adrenal gland, what's the emergency? So there are quite a number of disorders of the adrenal glands. Most of them you can live with them. So I picked only what is urgent, something that if not taken care of early in time, we might end up losing the patient. Yet if the things that help this patient survive are actually with us, we use them every day. So we're going to look at adrenal insufficiency, and it's the biggest adrenal emergency. So adrenal insufficiency is literally deficiency of adrenal cortex hormones. So we have less circulating aldosterone, less circulating cortisol, and at least at the bottom, low circulating sex hormones, but that is not an emergency. So we are going to basically look at the mineralocorticoids and cortisol. So there is something called Addison's disease. It's also known as a primary adrenal insufficiency. So when we are talking about primary and secondary in terms of endocrine, primary is what is affecting the gland itself. Okay, so when you find a primary endocrine disorder, for example, Addison's disease, which is a primary adrenal insufficiency, it means we are having problems at the adrenal gland itself. We are having insufficiency, so the factory itself is not producing enough. Then the secondary insufficiency usually is coming from the pituitary gland, where we have reduced levels of ACTH. So the commonest causes of Addison's disease, we have autoimmune destruction of the adrenal gland, infections like TB, HIV, syphilis, we know that TB, HIV, and syphilis actually have a higher prevalence in Africa and Uganda. So commonly, if you get a patient with an adrenal insufficiency, please rule out they are having HIV or TB or syphilis, as it's one of the common causes. We also have drugs such as ketoconazole, fluconazole, etomidate. So people who are working in emergency department and those who are working in theaters or the anesthesia team, we all know that etomidate affects functions of the adrenal gland. So for a patient who has a history of adrenal insufficiency, you would want to use etomidate cautiously. So we have things like hemorrhage into the adrenal gland that will cause ischemia and later on infection and likes. And then we also have pituitary hemorrhages. We have tumors in the pituitary gland and the adrenal gland itself. So this is just a note. So in things that in tumors affecting the pituitary gland, you will rarely have aldosterone compromised. Its production will usually remain normal. So as you're investigating this patient, usually they may have normal blood pressures, normal potassium, normal sodium, and that will help you differentiate between the secondary and the primary insufficiency. Next. Okay, so this is just showing us secondary adrenal insufficiency because the first ones were mainly talking about the primary. And in here we are saying commonly secondary adrenal insufficiency is due to damage or dysfunction to the pituitary gland. And so if we have a sudden stopping of steroid production, okay, we are going to get a negative feedback, okay, to the brain. And this negative feedback is going to show that I don't need cortisol anymore right now. I have in plenty. So ACTH is going to stop being produced and the adrenal gland will not be stimulated. So this is just showing you how a damaged pituitary gland is going to cause a failure of the adrenal gland from functioning normally. Let's continue. Okay, so what are the clinical features? So I know as you read through the slides, you may have found something called adrenal crisis. We are going to reach there, but these are features to show you whether someone has adrenal insufficiency. So most of them are non-specific. They are the common things we find. You may find someone with general fatigue.
Bring chapati.
So,
have you got chapati to eat?
Okay, thank you. You're going to find someone with general fatigue. They have malaise. They have general weakness. They have low appetite. That's their general being. They'll come to you and say, for about 3-4 months, I've been feeling lazy. I've been feeling tired. I have no appetite. When they stand up, they sometimes feel dizzy, especially on standing up position. Some of them may even be brought to hospital following an instance of syncope. They may have GI symptoms such as nausea, vomiting. Some of them or most of them will come to you with an acute abdominal pain. And what we usually think about is ulcers. So you need to be inquisitive further. However, I need to warn us, it's not a very common occurrence in Uganda, but with a change of diet, how we are living, with the occurrence of autoimmune diseases, we might start seeing adrenal insufficiency. So we need to be on the lookout. Then for females, they may have a history of amenorrhea, they are not breastfeeding, they are not on any contraceptive, they are not on anything. They may have times of amenorrhea. So you start thinking about them. Just a second. Sorry about that. So an increase in ACTH will sometimes give you an increase in melanocyte stimulating hormone. When you have an increase in melanocyte stimulating hormone, you may get hyperpigmentation, and hyperpigmentation may be one of the signs to show you that this patient may be having Addison's insufficient or Addison's disease. Next. Okay, so this is just a spectrum of the severity of adrenal insufficiency. You may have just an insufficiency and it's not really disrupting your day-to-day living. It's normal, it's okay, but you have the symptoms. However, you're still moving, which means you still have some cortisol being produced, you still have some aldosterone being produced. And in it, you normally have the non-specific symptoms like fatigue, anorexia, weight loss, dizziness. As you proceed towards the adrenal crisis, where we completely have a shutdown of production of cortisol, you're going to increasingly feel fatigued, anorexic, you have nausea and vomiting, diarrhea, syncope, delirium, and the likes. So when you proceed to the adrenal crisis, this is now called a shock state. And in it, you have hypotension, tachycardia, and all other features of adrenal insufficiency. Let's continue. This is still showing us clinical features of the adrenal insufficiency, but towards the end of adrenal crisis. Next. So investigations, how would you want to investigate this patient? You definitely do the routine examinations, the routine labs. You want to do a random blood sugar, and normally these patients will be hypoglycemic even after a meal, basically because cortisol helps us in metabolism. It helps the liver release glucose through the gluconeogenesis pathway. So if cortisol is reduced, chances are the patient will be hypoglycemic. Remember, we said cortisol helps us in the immune system. Usually they will be eosinophilic, they may have some lymphocytosis, they may have a neutropenia. In the RFTs, normally when we have a presence of reduced aldosterone, we are going to excrete more sodium. So we shall have a hyponatremia, and we shall be retaining more potassium. So we shall have a hyperkalemia. Usually when you do the ABGs, these patients will have metabolic acidosis. In secondary adrenal insufficiency, sometimes the ACTH levels will be low or normal. However, in primary insufficiency, they will usually be high. Like I said, this will be a negative feedback mechanism where cortisol levels are reduced, okay? So the adrenal glands are sending a message to the brain. I need to be stimulated, I need to work, okay? So the hypothalamus is going to release the corticotrophin release hormone down to the pituitary. The pituitary is going to release its ACTH in a bid to stimulate the adrenal glands. But remember, there is nothing coming out like cortisol. So more and more ACTH is going to be produced, okay? Yet in In times of secondary insufficiency, that's where the problem is at the level of the pituitary. We are going to be having insufficient or normal ACTH being produced. Okay, so you also want to do plasma cortisol levels, and anything that is less than 5 micrograms or microliters is usually diagnostic. The serum cortisol, we usually prefer the early AM cortisol levels. That's when the body has equally rested. We check if it's less than 5, it's usually diagnostic of a primary insufficiency. Next. Okay, so the monster adrenal crisis is an acute exacerbation of symptoms of adrenal insufficiency, and it occurs in patients who have adrenal insufficiency. They may be knowing that they have adrenal insufficiency. They may have been diagnosed previously, or this may be your first chance to catch the fact that they have adrenal insufficiency. So it's always associated with absolute hypotension, that's systolic less than 100 millimeters of mercury. And this hypotension is non-responsive to vasopressors, and it's non-responsive to volume repletion. So you have a patient with all the symptoms we talked about. They come in, you do your ABCDE, you find they are hypoglycemic, they've lost consciousness, you take their blood pressures, they are hypotensive, they are tachycardic, you put your 2 large bore cannulas, you give them a resuscitating volume of fluid. These patients are not picking up. You give them vasopressors like norepinephrine, dopamine, and the rest, and they are still not picking up. This is the time for you to start thinking, I think my patient has adrenal crisis or an Adsonian crisis. So it's life-threatening. Therefore, we have to recognize it as soon as possible. Like I said, in Uganda, I didn't find any literature on it. So the numbers, I do not know them because they are not documented. However, the British literature and American literatures call it a rare condition. But there is always a first time for everything. Like I said, we have so much HIV, we have so much TB, we are having an increase in autoimmune diseases. So it's important for us to be on a lookout for such things. A shot of hydrocortisone will give this patient a new chance to life. Next. So there are precipitating factors. Usually an adrenal crisis will not happen out of the blue. There should be precipitating factors, things that triggered this crisis to start. And commonly there are infections. They could be bacterial or fungal or even viral. In children, especially gastrointestinal illnesses, we have trauma, we have significant emotional distress, like loss of one. Then we have abrupt cessation of chronic steroid use. Then we have thyrotoxicosis. We all know thyrotoxicosis increases your metabolism, so it will require an increase in cortisol supply. In case you already have an insufficiency, thyrotoxicosis will precipitate a crisis. So who is at risk of an adrenal crisis? Anyone with history of an adrenal insufficiency is definitely at risk. If they get the likes of infection, they get GI illnesses, they get trauma, they are pregnant, they have significant emotional distress, they are at risk. Patients who are using chronic glucocorticoid therapy, for example, those with leukemias and other cancers, if you suddenly withdraw their therapy, they are also at risk. And then patients who are taking anticoagulants are at risk of adrenal hemorrhage. Remember, we said in our causes of adrenal insufficiency, we have adrenal hemorrhage. So if the infarction, goes to ischemia, and then we have complete destruction of the adrenal gland. Of course, we shall not have release of cortisol. Next. This is just showing us how the symptoms come about, the symptoms of Addisonian crisis. So we said we have cortisol that is being produced in low amounts, or it's completely absent. We have reduced liver function. Here we are going to have reduced metabolism. So our glucose levels are going to go low. They'll finally go extremely low. You go hypoglycemic and you become comatose. In the stomach, you're going to have a decrease in digestive enzymes. So you're going to get cramps. You may get diarrhea. You may also get vomiting. In the aldosterone side, your kidneys are going to lose more sodium and water. So you're going to have a reduced, a low fluid volume. Your heart, of course, if you have a low fluid volume, your heart is going to try to increase the rate at which it's beating so that it can supply the brain and the kidneys. But because the pressures are low, the cardiac output is also going to remain low. And in the long run, you're going to end up with shock that we talked about. Next. So clinical presentation, normally the biggest feature is shock. So you get a patient whom they say they had one episode of vomiting, 2 episodes of diarrhea, and now they're having shock. And you're like, but it was 1 episode of diarrhea, it was 1 episode of vomiting. They do not look, in the initial presentation wise, they were not very sick to be having shock. So the shock is out of proportion of the severity of the illness. Then you have the other non-specific symptoms like nausea and vomiting, abdominal pain. Sometimes you're going to think they have intestinal obstruction, they have a peptic ulcer disease. You're going to really think of other surgical illnesses, and the Addisonian crisis is going to come in much later. But this is one of the other features. They may also have unexplained fevers rather. You're failing to find the source of the fever. They are fatigued, they are lethargic, they may come in with confusion, or they may come in with coma. And then when you dig backwards, when you ask the attendants, they'll sometimes tell you, he has spent some 6 months complaining of fatigue. Every time he returns from work, he's too lazy, or sometimes he actually misses work. They are not able to eat well. And in developed countries, usually a patient who is diagnosed with adrenal insufficiency is given a medical card, and they are told to carry hydrocortisone in their bags. So this medical card, or an alert card, introduces them as patients with adrenal insufficiency. So if you find them collapsed along the road and they have such a medical card, you know that this is a patient who needs a steroid right away. Okay, next. Okay, so these are just still signs and symptoms. Let's proceed to the next. What do you want to do in the labs? You want to do the routine labs, you want to do your RBS, you want to do your CBC, and commonly these are patients who will be hypoglycemic, they may be hyponatremic, hyperkalemic. In their RFTs, they may have increased urea, showing that our kidneys are failing basically because of low pressures. And when you're doing other investigations, for example, if you're thinking if they have a fever and you're thinking they may be having an infection, you do a CPC, you can do a blood culture, you shoot towards a precipitant, what you think could be precipitating the current illness. So for every febrile patient who comes in and they're showing features of shock, please treat them as having an infection until they are proven otherwise. They may be having the Adsonian crisis, or they may be actually having septic shock. So it's best to start your broad spectrum antibiotics as soon as possible. And remember, as long as the infection is still present, our stress levels are increasing in the presence of low cortisol, so we are just worsening the shock state. You may also do ACTH and cortisol levels. These are usually taken off before you transfer the patient to their mother wards. So something here, do not wait for lab results before you initiate treatment. So things like RBS, these are point of care. These you should be able to do at the ED, at your health center. You should be able to do them in real time as soon as possible. Replace glucose, initiate the treatment as soon as possible. Next. So in management, you're definitely going to do your ABCDE. If they are unconscious, maintain patterns of their airway with oropharyngeal airways or NPAs, whatever you have in place. Give them oxygen if their SATs are low. Get 2 IV lines, large bore. I prefer green to gray to orange. If you have any of those 3, please get 2 lines. Give these guys or give this patient fluids. Correct their volume. So if they are hyponatremic, okay, and they have a sodium level that is less than 125, we prefer to use IV dextrose 5% with normal saline at a rate of 30 ml per kg. What we are trying to do is we do not want to reduce the sodium very fast. There is a phenomenon called demyelination when you rapidly improve sodium levels. So you be cautious. We prefer to use D5 with normal saline. Immediately give these people IV hydrocortisone. You start with 100 milligrams and then give them 100 milligrams 4 times a day for the next 12 to 24 hours. So the key thing here is start glucocorticoids immediately. Hydrocortisone is more preferred because it has both cortisol and aldosterone effects. So it's going to improve your blood pressure as well as provide cortisol that is important for metabolism. So you're killing 2 birds with 1 stone. So we prefer hydrocortisone. Someone is going to ask me, what if I can't get IV access at that point in time? You can still give this hydrocortisone intramuscular. It will still work, okay? Continue hydrocortisone 4 times daily until the patient is using IVs until the patient is able to take orally. Next. So if they have any other metabolic abnormalities, please correct them. If they are hypoglycemic, you give them 10% dextrose. If they are hyperkalemic, usually following fluid resuscitation, the hyperkalemia may recorrect itself. If it doesn't, then you may require specific treatments like the calcium gluconate, salbutamol, or insulin. However, you should be looking at how your patient is responding to fluid resuscitation. If they have infections, treat the infections. If they had events of trauma, you know what to do with trauma. If they have malaria, treat the malaria. If they are HIV positive and they've not started on ART, discuss with the ART team and see how to start them on ART. Okay, and if they have an adrenal tumor or a pituitary tumor, this is now where the surgeons come in and they do the needful. But key take-home messages are: the moment you think this patient may be having an adrenal crisis, it does not kill if you give them hydrocortisone. It will save them. Hydrocortisone is available. I know it's there in most of our centers. We keep giving it to people. So for patients who are in shock, that you can't understand why they are having the shock, you've tried to resuscitate and they're not coming out, please give the hydrocortisone. It won't kill them. It will save them. Next. Okay, that's just a summary of the adrenal crisis. Since you have the slides, you go through it. Next. Okay, so the other emergency I want to talk about is pituitary apoplexy. It's also not very common, but it would be nice if it does not get us off guard. It's an acute life-threatening infarct or hemorrhage into the pituitary gland. So we know that the pituitary gland is also known as the master gland. It controls the negative feedback and positive feedback mechanisms. And it's located in the cella tussica of the sphenoid bone. It's divided into two parts, the anterior and posterior pituitary gland. The anterior gives us about 6 hormones that work on effector glands like the thyroid, the adrenal, the ovaries, the testes, and the likes. Okay, next. So on the left, we have the hormones secreted by the anterior pituitary. We have the growth hormone, we have the thyroid stimulating hormone, we have the adrenocorticotrophic hormone, follicular stimulating, luteinizing, and prolactin. So the last 3 are more reproductive, and the upper are more metabolism. The posterior pituitary secretes oxytocin and vasopressin. Vasopressin is important in maintaining blood pressure levels. Oxytocin, we all know it's the hormone responsible for uterine contractions. Next. So pituitary apoplexy. So the pituitary gland is a very small gland, very small, very tiny. It's like the size of a grape, kind of. So if you have hemorrhage into that gland, okay, you're going to cut off blood supply to that gland. And when a blood supply is cut off, you're going to get what we call an infarction. After an infarction, we're going to get what we call ischemia, okay? When a part becomes ischemic, it dies off, so it cannot do its normal job. When the pituitary is cut off, literally your entire body is almost cut off. We've seen all those hormones that are produced, all those hormones, some of them like the thyroid stimulating, like the adrenocortical, they are all important in day-to-day activities of your body. So if they are cut off, of course, this is an emergency. Now, if you find a patient with an acute severe headache, it could be accompanied by nausea and vomiting. Usually, this patient may be pregnant, or they may be known hypertensive. You start thinking, you start thinking of having pituitary apoplexy as one of your differentials. These patients may have ocular pulses, because the third nerve is just passes along there. So if you have things like tumors, if you have swellings of the pituitary gland, they may compress the third nerve, and you get a third nerve palsy. Sometimes you have a compression of the optic chiasma, and these patients may have reduced visual acuity with visual field defects. They may come in with fevers, stiffness, neck stiffness, photophobia. They may come in with reduced levels of consciousness. And sometimes we are going to manage them as patients with meningitis or a subarachnoid hemorrhage. Next. Next slide, Hilary. Next slide.
Connie, your internet is a bit slow, but you could, ours is a bit slow, but you could go on presenting.
I can't present if I don't have my slides, unfortunately.
Okay, 1 minute and then we shall resume.
Okay, it's all right.
In the meantime, if you have questions, please share them in the chat and kindly note down any questions you might have. Shortly after this presentation, we shall be diving in straight into the next presentation about nursing care with Surgeon Osire, and then address the questions. Okay, Dr. Connie, we are good to go. Are you able to hear us?
Yes, I am.
Okay, please carry on.
So for every patient in whom so you have a patient with severe headache, which is acute onset, and you've excluded the subarachnoid hemorrhage, you've excluded the meningitis or an encephalitis. Please think of a diagnosis of pituitary apoplexy. Those who have neuro-ophthalmic symptoms, you also start thinking about pituitary apoplexy. Then patients with pre-existing history of pituitary tumors, you can make a diagnosis. Okay. Maria, I have lost you people.
Yes, Connie, shortly. We shall be
Okay.
sharing the screen in a few seconds.
Okay.
We do apologize for the interruption.
Pardon, I didn't get that.
I'm saying that we will be sharing the screen in the next few minutes, and we apologize for the interruption.
Maria, your internet is not nice.
Yes, that is correct. We are having a few troubles with the internet, but we shall be correcting that in the next few minutes. Yes, Connie, are you able to see the screen? Are you able to see the screen, Connie?
Yes, I am able to.
All right, so you have about 10 minutes to the end of the presentation.
Yes, next. Those are some of the precipitating factors. Let's go back. Yeah. Hypertension, a major surgery. Let's go back to the precipitating. Okay. Patients who are using anticoagulation therapy, pregnant mothers, and those who have just had deliveries, especially mothers who had eclampsia and preeclampsia, and then patients with head trauma, they are at an increased risk of pituitary apoplexy. Next. Management, of course, we know the emergency management is usually ABCDE. Ensure the patient is hemodynamically stable and initiate steroid therapy. That's hydrocortisone IV. You can give between 100 to 200 milligrams. And so in patients who are hemodynamically unstable with an altered level of consciousness, they have reduced visual acuity, hydrocortisone is potentially life-saving. Next. You would want to do labs such as RFTs, CBC, a clotting profile. These are really helping you to wholesomely manage your patient. And then you want to do imaging, a CT brain, but the MRI of the brain is the imaging of choice. However, if you do not have it, you would go in for a brain CT, and usually you either see the infarction or you either see the tumor and all that. Next. Thank you. Those were my references, and that brings me to the end of my presentation. Thank you so much for listening to me.
Thank you, Dr. Connie. That was an excellent presentation. I love the interaction on the chat. Keep the questions coming in. So we shall move to the next presenter. Mr. John, please carry on.
Thank you. And if I'm being heard, audible enough. Yes, thank you, Maria. Yeah, I'm going to continue with where Dr. Connie has left it. Dr. Connie, thank you so much. You have actually did the presentation justice, especially where my nursing care comes in. Yeah, you've tackled most of the main points. I will be tackling. That means I'll be running through them since you already handled most of them. Thank you so much. Once again, I'm Osire Andrew. I work in Mulago as a critical care nurse. I'm going to go through the emergencies, the common adrenal emergencies. When I got this topic, I went through the ICU admission book, and with our diagnoses, I was able to get the top 3, most of them that we have in the ICU, and here is what we have. I'm going to use the nursing process where we have assessment, diagnosis, planning, implementation. Let's move forward. Okay, so DKA is what we're going to look at. When we're assessing this patient, what do we look at? As the pre-questions were, I saw there was a question and some people were failing this. What is the nature? You are going to assess the nature of the breathing. How is this patient breathing? Most of them have fast and deep. Not most of them. The patients present with the fast and deep respirations. That's the name we call them, KUSMO. Depending on your language, that is how it will sound. When we assess what do we find with these patients, they also have increased thirst, polydipsia. They have extreme hunger, where they are trying to eat to replace what they are lacking. We also had a question about what kind of breath, the smell that we can perceive from them. It's a fruity breath that comes out from them once they are admitted. What we also see from them, most of them have frequent urination. Within every few minutes, you can now, those we have in the ICU, within every 2-3 hours, your urine bag is frequently empty. These patients are going to have nausea and vomiting. And then they are going to also have abdominal pain. Finally, they will also go into coma as we proceed. Next slide. Next slide, please. Thank you so much. Okay, internet, let me continue with my other backup as we come on board. So we are going to the diagnosis, where we're going to have ineffective breathing pattern related to deep and fast respirations. Okay, apologies for what happened. Let's continue. My PowerPoint is not seen. It's coming. Okay.
Audible.
I'm audible. Give me the slide of adrenal crisis. Yeah, as I said, Dr. Connie had already talked about most of this. What exactly is happening here? We are seeing a patient who has these patients in the nursing care with once received in the ICU. Which slide is that? Adrenal crisis. That one, exactly. Thank you so much. Yes. We are having a patient who has, most of them have low cortisol, where we are seeing this is going to control the sugars and aldosterone, the BPs, the stress BPs, electrolytes, both cortisol and aldosterone are going to be controlling and balance our body systems. So under assessment, as with nurses, what do we want to assess and find? We have admitted the patient. You're going to find this patient who is hypotensive. And as we had discussed earlier on, this is a kind of hypotension that cannot be relieved either by vasopressors or by giving a number of IV fluids running. These patients are also going to an assessment. You find them when they're hyponatremic. Why? Because of the low steroids that we are having, aldosterone and the cortisol, which are low, and since they are low, they are not able to balance our body systems, the electrolytes well. So we are also going to have hyperkalemia. One of them will have to go up, one will go down. So the sodium will be down and the potassium is going to be up. So I've always said this, that potassium is one of the most deadliest electrolytes that must be controlled. Once it is out of control, it's the one that can easily lead to a cardiac arrest easily. So this patient also is going to present with hypoglycemia. We can go to the next slide. Low sugars, because we have not able to, the hormones are not able to balance it out. Nursing process, what are we seeing in this patient? We are having risk of the fluid the patient is receiving is not enough, so there's a fluid imbalance, fluid volume. As we have seen, the aldosterone production is not adequate to give us enough fluid. That speaks to us why we are hypotensive. And then we are also going to have the nutrition is going to be less than what the body requires to use. Still, also this brings us to cortisol. And there is going to be a risk of infection, as doctor has also just said. So most of these patients, we are going to see how do we handle this as nurses. The patient is in the ICU. Next slide. Thank you so much. So what do we plan to do with such a patient? You've received them in the ICU. These patients are, most of them are, this is a patient in the ICU, you've ventilated, you're intubated. We are going to monitor your vitals, your blood pressure. We have said the patient is hypotensive, BPs are running, they are low heart rate. We are running fluids, but nothing still is ongoing. So what do we need as our primary pause? The primary thing, as I said, I always teach nurses and I tell them Addison means you are going to add son, add steroid, add son. So you are adding it because there is lack of it. So we are going to add. What do we need? We need hydrocortisone on board. That's our first medication that we need on board. Then we can now continue with our IV fluids to maintain them. These patients are in a severe state. Check your oxygen levels. If they are low, you need to give them max so that you can achieve a good SATs of the patient. Nutrition-wise, so sodium is low. We need to make sure as a nurse, you're going to feed this patient so that you compensate for the lack of the low nutrition, especially the sodium, which is not balanced well, and the K that is extremely high. So that's why we have to constantly monitor. And in the intensive care, it's always hourly. You are documenting everything, heart rate, BP, temperatures, which are high. You're doing ABGs, which are done according to how the intensivist may require. Your blood sugars are also being monitored. So under labs, you make sure you run, you draw up samples, can do labs, random cortisol levels, ACTH, can also be done. Risk for infection, what are we going to do here? We are planning, and what are we going to implement in case there is an infection? So our IPC measures must be on board. Next slide. So you need to do your IPC where you have to wear gloves, protect yourself, hygiene. Thank you. Next slide. And after you've administered your fluids, how is your patient? How is the state? we shall achieve a state where our patient's blood pressures are stable. You've given the fluid, you've given the hydrocort, and there will be proper hydration of the patient. Thus, we are getting a patient who is now hemodynamically stable. Nutritional status. Normally, we like to involve a nutritionist. If the patient is on parental feeding, we can give them the carb events that go through for over 24 hours to run through. Reduce risk for infections. You make sure the patient has attained, you check a background check on their immunizations and prompt treatment for infections. So next slide. I think we are done with that presentation. Let me talk about thyroid storm as we also finish up. So this is thyroid storm. Yes, thank you so much. This is a complication that also arises from hyperthyroidism, where there is excess thyroid hormone production. On assessment, what are you going to expect? Assessing the cardiovascular system, the status of your cardio system, how is it? Of course, what is happening here, everything is in excess. It's a storm. As it appears there, it's a storm. Everything is so fast. Your patient is complaining, orthopnea, they are tired, they easily get exhausted. What is happening to the heart? The heart is having a tachycardia, which goes into supra too fast over 150, then it quivers, ending up giving us arrhythmias, which are unstable. So this patient stands a risk of getting an AMI. Let's first go back to the previous. Yeah, so we are going to monitor also the CVP, central venous pressure. Next, previous slide, please. We are monitoring the CVP, the first slide. CVP. Central venous, so we are moving the previous slide where I was on thyroid storm. Yes, there. Thank you. No, the previous one. Patients are easily going to be fatigued. Once these patients are admitted in the ICU, we want them to be in a quiet environment. We want to do as less procedures as we can on such a patient with a storm, because you need to give them, they are easily stimulated and they spike back to such a crisis whereby the BPs, everything spikes high. So these patients are going to become hypertensive. The fevers are going to be really high, tachycardia. As I said, they may even end up in a myocardial infection, and they can end up having a respiratory failure because of the too much workload. That is fast. They are restless, they are irritable. So these patients, we intubate them, mechanical ventilate them. You only do suction when you must do it, because we are trying not to stimulate and make them wake up. So the environment must be clear. You feed them. When we need to give them now drugs that control reduce on the thyroid hormone levels. As per doctor's order, we want to give them, there's a drug, a solution that we call Mulago solution that is comprised of potassium iodine and iodine. You can put it in the NG tube, give it to the patient as per route, depending on what the doctor has preferred. Then you give this patient, then we can also give them thyroid hormone drugs that prevent the secretion, methimazole. This drug is used also in thyroid storm. However, you need to confirm if you're in the ICU, in the wards, you want to give this drug to a patient, especially a female, need to confirm in case, make sure she's not pregnant. If she is, it's a high-risk drug. In the first trimester, we don't use it. There's a drug called PTU, propylthiouracil. That one is safer, at least you can use it in pregnancy. However, it has an effect of liver failure. So you need to do your LFTs well to be sure. that this patient is not going to liver failure. Also, as you're giving these meds, watch also to make sure you don't go into hypothyroidism, however much you're fighting a crisis. So we also give these patients a beta blocker that prevents the conversion of T4 to T3. Yes, please. So that we also ensure that our storm is gone well. Some patients will complain of they have a metallic test after they have taken the glucose solution, but it's expected. That is all part. Can go to the next slide. Oh, okay, yeah, that is it. So most of them are going to complain of this their processes because everything is happening fast. Some of them can become kind of delirious. They may not be aware of their environment, fully oriented to person. So how do we get these patients back in time and get them fully oriented? We provide them with you can make sure in the room where they are, there's a clock, there's a calendar. You sensitize them and bring them back to reality. Next slide. Those who are in ICU and they're recovering, we also start to assess them. So at the end, what am I achieving? I'm going to achieve an adequate cardiac output. My tissues are well perfused, and there will be evidence by me having stable vitals with good peripheral pulses. Fatigability, I will have increased energy, and my patients will stop complaining of a loss of energy. Most of them those who have a disturbed thought process, they will start to think well and they'll be well oriented. I think my slides are over. Thank you very much. Over to you, Maria.
Thank you so much, Mr. John Osire, for keeping time and for an excellent presentation. So in the chat, we do have a few questions coming in. Please keep the questions coming in. So any of us, if you have questions at this point, you can feel free to unmute and voice your questions. And please mention who you're directing the question to, if it is either Mr. John, Dr. Ronald, or Dr. Connie Baluka. Anyone?
Hello, everyone.
Yes.
Hi,
Hello.
can you hear me? Yes.
Yes,
My
you are
name
very
is
audible.
Yeah. So my name is Lillian, and I'm a nurse here in the UK, but I'm originally from Uganda. So I got this link. I just stumbled on this presentation. I'm an endocrine specialist nurse, and I thought I should attend when I saw it's about pituitary disorders and stuff. I just wanted to add a few points from the nurse's perspective in regards to management of patients with adrenal crisis or adrenal disorders emergencies. I think I want to appreciate the presenters. Of course, it's been very lovely. But I just wanted to add my voice to the nursing management, and mainly to do with nursing education. Because, you know, as nurses, if we do not educate our patients about their conditions and how to manage and how to cope and how to prevent, they are going to keep coming back to the hospitals, because at the end, we might treat them for this one instance, but you know, when they go back home, they should know what to do and maybe how to prevent any further crises. So with adrenal crisis, in most times in the setting, like in Uganda, of course, it's different here. But in Uganda, it's more like when patients appear with a crisis, they've not been diagnosed with adrenal insufficiency before. So maybe that's going to be the first point of diagnosis. That's when they're going to know they actually have insufficiency cortisol in their blood, or their adrenals are not functioning very well. Whereas here, maybe patients, when they present with symptoms like fatigue, weight loss, and low blood sugars, hypotension, they are screened and maybe their cortisol is done. So they get to know they have adrenal insufficiency, started on hydrocortisone way before they present with emergencies like adrenal crisis. So, but in the setting, like I'll bring it back to Uganda and just add like a few points. In our setting back in Uganda, if you have a patient comes in with adrenal crisis, is in the ICU, is having hydrocortisone going, is having fluids being replaced and all this care, it's very important to teach the patient on how to prevent further crises in terms of sick day rules, in terms of emergency hydrocortisone injections and stuff, in terms of I don't know if in Uganda we do give steroid cards. I don't think we do, but to let health workers know if they appear to have certain symptoms and they've appeared at the ED or go to the hospital, the first thing they should let the health worker know is, I had adrenal crisis before, or maybe I had adrenal insufficiency before. So then it can trigger them to know the first thing you're going to do is hydrocortisone, because it's really very life-saving. So I don't know if I can go through the sick day rules. I mean, could be too much. I don't know how much time is in here, and given that I just, popped on here, I think it could be too much, but I'm happy to share maybe, the documents in terms of the sick day rules and when the patient should, the symptoms they should look out for an impending crisis, how to prevent that, and keeping themselves with maybe hydrocortisone all the time, and knowing, when to seek for help. So
thank you, Vivian. Thank you so much. I think it will be really helpful if you could share that in the chat, and people could have a link to that information. To be extremely helpful. And then also in the chat, we do have a link for giving us feedback. Kindly follow the link and give us feedback. Any other person with a question or any other points you'd like to add on for the presentation? Yes, Dr. Eemu, do you have any questions in the chat that you think would benefit from on the platform?
Thank you. So most of the questions have been responded to. A majority of them were perhaps more of individual knowledge seeking, of not to share maybe with everyone is one. An individual asked how to reconstitute or get a D5 normal saline. So there are prepackaged solutions on the market. They're not, however, so common in our market, but they are available in some facilities. I guess cost is a limiting factor. So the best thing to do in our setting for most situations would be to reconstitute a D5 saline from the available solutions. Usually you have saline in plenty and D50. Simply pick your 5 ml bottle or container of normal saline, remove 50 ml from it, and pick 50 ml from a D50 solution and replace into the saline bottle. That will give you 500 ml of D5. You can't call it normal saline anymore because of the portion of sodium chloride you've removed. However, it's close enough to 0.9% normal saline. Yeah. Basically, that's the question I would possibly want to share with among the questions that I got in the chat. Thank you.
Thank you, Dr. Eemu. That was an excellent explanation. Also, we have Janet, who is talking about the tapering of steroids instead of abruptly stopping the steroids. So if you have any more questions in the chat, or you have questions you'd like to voice, feel free to voice them, unmute the mic, and let's hear from you. In the meantime, we shall be preparing for the post-test.
Hello.
Yes, Janet.
Hello, hello, this is Barry.
We all right? How are you?
Very well, thank you. I just want a clarification. If if you are to correct hyponatremia, how much should you give in what period of time? Because it happens, people tend to hypovolemia or hemodynamic instability is a concern with adrenal crisis, and oftentimes they also come with hyponatremia. So how much within 24 hours should be the target if you need to really correct the sodium? I think that goes to Dr. Connie.
Okay,
Thank you.
Dr. Connie? Yes,
Thank
should
you.
like to pick.
Thank you, Eric. I hope I got your name well. So the goal here, that's why we said we want to use dextrose normal saline, because by the time you have dextrose normal saline, you reduce the strength of this normal saline. And usually we want to correct not more than by not more than 10 millimoles per day. So the correction factor or how to correct it will really depend on how bad is the hyponatremia. Because if it's very bad, sometimes you may need to actually give hypertonic saline. So it's not a static corrective measure. It's a patient dependent. So you're going to look at the patient individually, how much fluid do they need, how bad is their hyponatremia, and how best am I correcting it? So you're going to have serial sodium levels to check on how above the baseline am I, how far am I from the baseline. So it's recommended that you don't do more than 10 millimoles of sodium correction per day. So like I'll still say it, there is nothing cast in stone that you're going to give 2 liters, you're going to give this much. And remember, I said in Addisonian crisis, even if you bolus these guys with plenty of normal saline, usually you're not going to pick them out of the shock. So it's the hydrocortisone or the steroid that is going to pick them. And then you're going to give fluids depending on how they are responding to those fluids. So there is no static dose, but you could start with 30 mL per kg, run it in an hour's time, reassess the patient and decide whether to add more or not. Thank you.
Thank you so much. I know we all still have a lot of burning questions. We can keep them coming in the chat, but in the meantime, we are going to do the post-test in the next few minutes. So Dr. Ronald, is there anything you'd like us to take home from the presentation you made today?
From the case presentation, my main take-home message would be look out for first of all, there are those diagnostic signs and symptoms that patients will present with. Then there are those other features which cut across, which you will find in which are not specifically diagnostic to a particular problem, but rather to just an alteration in the normal physiology, which can happen either as a result of, it could be an adrenal problem, or it could be a problem with any other hormonal secreting in the body. So basically, someone's mic is not muted.
Thank you.
Basically, that is my take-home message for today.
All right, thank you, Ronald. John, is there any particular thing you'd like them to take home from the presentation today?
Thank you so much, Maria. As my colleague shared from the UK, that the earlier we get diagnosed, the earlier you get to know your status about the adrenal crisis levels, the better you prevent yourself. And what keeps
the doctor away.
Keeps the doctor away. Thank you so much.
Thank you, John. Dr. Connie, over to you. Any take-home message?
So take home, adrenal insufficiency is quite deadly. Don't fear to use the steroids you have. My people, if you do not have hydrocortisone, you can give the dexamethasone, but its effects are not going to be as good as those for hydrocortisone. However, have a high index of suspicion. And my colleague, I think he's David from internal medicine, he'll attest to this. Actually, I found out if you give steroids to someone who is very sick, they're actually useful because, yes, when they are sick, their adrenals are not working. So have a high high index of suspicion, and a steroid, hydrocortisone won't kill the patient, it will instead save them. Thank you.
Okay, thank you. And Dr. Eemu? All right,
Well,
so let's go on.
I think I could just re-emphasize on the aspect or the question that Eric asked earlier about sodium correction and how fast, how soon to do it. Dr. Bonaventure has some responses. The question also on the chat. But like Connie said, it's not cast in stone. Ideally, this is a patient that you are closely monitoring, and basically, I could say you are by their bedside. Our only limiting issue in our setting is that you don't have access to frequent tests to reassess, let's say, the level of correction made. So in a case where you have a patient who needs sodium correction and you have limits that you do not want to exceed, let's say 10 millimoles in 24 hours. This is a patient you're giving both fluids and steroids, and hopefully your steroids would give you a better response in a shocked state where you possibly are going to introduce vasopressors. And once your patient is deemed euvolemic, you don't want to give more fluids, you might have to bring in hypertonic saline so that you can help you restrict volume. There are calculations that you can use to estimate a volume of hypertonic saline that you can give, and you use the patient's current levels of sodium to make such calculations. The estimates are quite close enough to being accurate, and they can help guide your management of your patient. Yeah. Yes, hyponatremia is a big issue in these patients. However, if you overcorrect them, you predispose them to more complications that you didn't want. That is ODS. So it's very important to watch that and make sure you take great caution in the correction. Thank you.
Okay, thank you so much. So we'll proceed to the post-test. All right, okay. So we'll get a few closing remarks and then finalize with the session.
Thank you so much, participants, for joining into the 69th ECO session. we've transitioned to the iEcho platform, and this has been our first session on the iEcho platform, and I understand that there's been a lot of struggle because people are still getting to know how to navigate the system and join the sessions that we shall be hosting in the subsequent sessions. The advantage with the iEcho platform is that it is a one-time off registration. You don't need to keep registering like what we have been doing for you to be able to join in every single session that we have been having. So this one, as long as you've registered on the iEcho platform, you will have access to the subsequent sessions that we shall be doing, and you won't need to again register for those sessions. For those of you who have already boarded onto the iEcho platform, you can see that our next session is already pre-scheduled, and you can view it and plan ahead of time to join that particular session. The other advantage that it has is that it can host more people than Zoom does. So it gives us opportunity to host more than 500 people, which has been really our greatest struggle as the EMS ECHO Secretariat. So we hope that this platform will give us better experience. I totally understand that there's been a lot of struggle today. We are going to come up with a short video, 1-minute video, or now you can get to register on the iEcho platform, and then and also how to access the sessions that we shall be doing. The other advantage that also this platform offers to us is that we are going to be uploading the session materials on the platform, so you can feel free to access the materials at any time without having to send any of the secretariat an email to actually share the presentation with you. So all the presentation that has been done today will be uploaded on the platform, and you can access at any time of your convenience, including the videos of that session, just in case you would want to remind yourself about particular things that were said in the session. You can always have that at your convenience. We shall also be sharing the CPD links, the CPDs on the iEcho platform. You do not necessarily have to register on a CPD link, so it will be quite easy for us to keep track of your CPD points and the certificates as well. We shall also be sharing the certificates. You basically just have to go and download your certificates on the iEcho platform once you meet the criteria for you to qualify for the certificates. We shall keep orienting you to the iEcho platform, and I hope that we shall have a much better experience with this new avenue that we're having to conduct the echo sessions. I thank you. We are going to put on our videos so that we can have a screenshot of this session. We want to thank our participants. I think it has been quite an elaborate and interactive session, and we thank you. We have a poll, if we can do that in 2 minutes before we can take our screenshots, I think it would be good. So we can know that these wonderful people have been impactful, and they are going to enhance how you take care of patients with adrenal and pituitary emergencies. That has gone up so fast. Could we relaunch? All right, if you can just put on your videos so we can have the smiles and share a photo moment together. Dr. Bonaventure, good to see you. Good to see you. I have also noted a number of people today have logged in with Andrew to the MakCHS profile. I know that is going to be changed in the next session when we get more familiar with the iEcho platform. A number of people haven't yet turned their videos on, and you give us those smiles. Good to see you all. Rose.
Thank you guys for this session. It has been wonderful. Though me personally have been disturbed by the network, I hope next time it will be better.
Yeah, we hope
Thank
to
you.
have a better experience next time. Thank you so much for that feedback. We very much appreciate it. I can't see anyone in the video. I don't know what has happened. Keep the comments coming as we take our photo. All right, smiles. Thank you. We look forward to having more and more of you in the next session. And please be an advocate of helping your friend to navigate that session. Over to the moderator to conclude the session.
Okay, thank you, Jimmy, for that communication. And thank you. I would like to thank the panelists once again for the wonderful presentation. And that will be all for today. Thank you for joining us. We apologize about the post-test, but for those that were able to do it, thank you once again. Otherwise, have yourselves a good evening.
Jimmy, should I end the meeting session?
Yes, you can, and feel free to end the meeting.
Okay, thank you so much.
Thank you.
Thank you.